Thank you very much, dear Chairman. I am grateful and always honored to Professors Padaletti and Granda for inviting me back to share some time with you. My charge today is to talk about this new drug, LCZ 696. From my personal viewpoint, I think the introduction of this drug has reinvigorated the entire field of heart failure. Whether or not this drug will be the total formula to treat HFrEF or systolic heart failure, I'm not sure. But what it has done is to tell pharmaceutical houses and scientists that we have lots to gain by moving beyond the renin-angiotensin system and finding new pathways. And so I'll spend just a few minutes trying to impart the enthusiasm that has been generated as a result of this new drug. I have no disclosures. It is worthwhile showing this very humbling slide, which indicates that neprilysin is not a new discovery. What you see up here is that renin was discovered many, many years ago at the early part of last century, and angiotensin was isolated in 1940. Going to more modern times, in 1970, the angiotensin converting enzyme was isolated, and shortly thereafter, the neprilysin enzyme was discovered. So if you are like me, it was not on my radar screen, and I've had to learn a lot about what this neprilysin is. And in fact, moving down here, you'll see that the neprilysin inhibitor was really characterized earlier than the initial discovery of natriuretic peptides, and so the relationship between neprilysin inhibition and the resulting effect on natriuretic peptides really could not be appreciated. Okay, I promise this is the last of these overwhelming slides. So you all are experts on this side of the equation. We had to learn about the effect of beta blockers on the sympathetic nervous system, and we've memorized the impact of angiotensin converting enzyme inhibitor, as well as the role of angiotensin II on the receptors, as well as we've just been refreshed by Maria Rosa on the impact of aldosterone. But on this side, we're not so good. And we have to remember that natriuretic peptides are increased while the renin-angiotensin system is likewise stimulated. And as natriuretic peptides are increased, wall stress is the stimulus for this. The resultant natriuretic hormones interact with a natriuretic peptide receptor, and as you also saw from one of Maria Rosa's slides, this impacts on cyclic GMP and has a variety of functions. The neprilysin inhibitor, in this case LCZ 696, interacts both to block the breakdown of the natriuretic peptides and as well as interacting with the angiotensin receptor blocker. So that's the pathophysiology which we now have to learn. Here's a couple of other things that I think are important as we try to get our arms around this new class of drug. The circulating natriuretic peptides are cleared through two principal mechanisms: a natriuretic peptide receptor-mediated clearance that I showed you on the previous slide, and enzyme degradation. Now, this enzyme has had multiple names throughout the last decade or so, and I have found that confusing. It's been called neutral endopeptidase, it's called common acute lymphoblastic leukemia antigen, but more recently it's been called neprilysin. And so you can forget all the other names. The new name is neprilysin. The second thing to remember is we heard great excitement about omapatrolat. Let me remind you that omapatrolat is very much like LCZ 696 with one important difference. It was a combination of neprilysin inhibitor and an ACE inhibitor, not neprilysin inhibitor and an ARB, or angiotensin receptor blocker. And just very briefly to remind you about the effects of omapatrolat in heart failure, there were two key trials. One was the IMPRESS trial, which compared omapatrolat with lisinopril, and it showed a strong trend in clinical improvement. And the larger Overture trial, which involved almost 6,000 patients, and the primary endpoint was not significant, but there was a significant reduction in the secondary endpoint of cardiovascular deaths. But that's when the adverse signal of angioedema was noted. And this became an important and actually lethal effect for omapatrolat. And it was the impact of angioedema that stopped the study of omapatrolat. Finally, to remind you about angioedema, and perhaps in my country it's more important of a side effect than in your country, because angioedema does occur more often in blacks. It also occurs more often in Asians, so it's not just an American problem. It's a problem many places in the world. And in black patients, however, the incidence of angioedema is greater for both agents, either omapatrolat or lisinopril. But we have to remember that it's a potentially life-threatening complication. And the reason that the combination of the neprilysin inhibitor and the ACE inhibitor is important is that there appears to be a synergism between the ACE and neprilysin inhibiting actions of omapatrolat, so that there is higher levels of bradykinin. And in addition, omapatrolat inhibited a third enzyme, which you don't have to remember, which is also involved in the breakdown of bradykinin. So it seems to be the bradykinin is the agent that increases vascular permeability and fluid extravasation. So let's just talk very briefly about some early studies with the neprilysin inhibitor. In this case, they were looking at the impact of neprilysin inhibition in systolic blood pressure. By the way, the name of the neprilysin inhibitor is sacubitril or sacubitril, or however you want to say it. It does not roll off the tongue, at least in English. Maybe in Italian it sounds more beautiful. But this is the effect of the neprilysin inhibitor alone on blood pressure. So you see alone the drug is not particularly good at lowering blood pressure. It's equivalent to valsartan alone, but when you add the combination of sacubitril and valsartan, or in other words, LCZ 696, you see the combination is better than either one alone, and so on as you get higher doses. There's a very important effect on blood pressure, but these are patients that don't have heart failure, and that's important to remember. There is a whole host of interesting studies going on the role of neprilysin inhibition and the combination of neprilysin and angiotensin receptor blocker. I'm going to show you just one that was published a few months ago that looked at the impact of LCZ 696 on cardiac remodeling and reducing cardiac fibrosis. And here is the control. Here is just infusing angiotensin II. Here is the effect of a drug that is the neprilysin inhibitor alone. Here is the effect of valsartan alone, and the orange is the combination, or LCZ696. So again, a very important synergistic effect in this case resulted in an attenuation of cardiac remodeling and dysfunction after myocardial infarction, and this was better than either drug alone. A second study that I wanted to share with you that was published last month looked at soluble neprilysin as a biomarker predictive of cardiovascular death and heart failure. And again, if you look at event-free survival, those patients that had the lowest levels of neprilysin survived and were free of cardiovascular death or heart failure hospitalization or cardiovascular death. So it turns out to be consistent with the data that I'm about to show you. So here is the New England Journal article that came out on an ominous day of September 11th. And I'll take you through a couple of important points talking about adverse effects. These patients all were on either ACE inhibitors or ARB, and they had about a 2-week run through where they were washed of both ACE and ARB if they were on them. And so 10,000 patients had to be able to tolerate 10 milligrams BID of enalapril. And so you see about 5% of patients could not tolerate that. There were a variety of other reasons. Then the resulting 9419 patients then had to go through about a 2-week testing of the LCZ696. And the patients that were, and another 5.8% of patients were discontinued. And so the resulting patients were the patients that were randomized. This looks at the breakdown of the patients. And again, most of these patients came from Western Europe and Central Europe. The role of America in clinical trials is waning. And also you see that only about 5% of patients were Black, which is an important endpoint in my country. And here's the data that made a lot of exciting news, that there was a highly statistically significant decrease in death from cardiovascular cause and death from any cause as a result of LCZ696 compared to valsartan alone on top of good medical therapy. And in fact, in addition, there was an improvement in quality of life as measured by the Kansas City Quality of Life Questionnaire, no difference on atrial fibrillation, and no difference in decline in renal function. I want to talk 1 minute about adverse events. Yes, there was more hypotension in the LCZ696 compared to enalapril, and that was significant. But interestingly, there was a higher incidence of renal dysfunction in the ACE arm rather than the LCZ696. And I think most importantly, look at the very, very low incidence of angioedema. Who are these patients? These are patients who primarily are class 2. As you see, 70% in class 2, 24% in class 3, compared to other studies where there were a percentage of patients who were in class 2. They all had low ejection fractions, and they were very well treated on optimal medical therapy. And that resulted in a number needed to treat of 35 to reduce all-cause mortality. And this is put in relationship to some of our other pivotal trials. There was a second publication in Circulation that said that LCZ696 reduced the time to first hospitalization as well as cumulative hospitalizations so that it really keeps people out of the hospital as well as keeping them alive. So John McMurray has summarized this by saying we've moved from a balance of vasoconstrictor, antinatriuretic, and pro-mitotic mediators, so lovely articulated by Dr. Costanza, and very little vasodilator natriuretic, to one of neurohormonal modulation, where we are reducing vasoconstriction and enhancing vasodilators. And it's really changed what we're going to have to do in the future. Where are the neprilysin inhibition and or ARNIs going to fit in this stepwise progression? I'll finish by suggesting that there is an ongoing study looking at LCZ 696 in diastolic heart failure, HFpEF. The Paramount trial was extremely exciting, suggesting that there was a signal, and we're waiting to hear the Paragon trial that's coming on from now is in enrolling patients. We are going to have to do some work to learn about this drug. There's going to be some clinical pearls about how you switch your patient on ACE inhibitor and ARB onto the new drug LCZ 696. So just like we had to learn about beta blockers and we had to learn about ACE inhibitors, now we're going to have to learn about this new class. But it's an exciting time for our patients, and it's an exciting time to hope for even more therapies. So thank you very much.